If you'd like, I thought I could lead us through just a little bit of movement practice, then we can dive into our discussion, but sometimes things get kicked up in this powerful film. So if you'd like, you could just take a moment, and again, panelists, feel free to join in. You can turn your cameras off or have them on, or just do a little neck, shoulder movements, but you're welcome to take a moment and just kind of land in the space that you're in. That could be visually, right? Like looking at your surroundings, locating yourself. Another way that you might locate yourself is through noticing your body. So you're welcome to possibly bring awareness to your body through some movement. And one way you might move could be to just move your chin from side to side. And again, feel free as you're here. You might be listening, you can join in, only if it's useful for you. So you can move your head maybe from side to side. Maybe you bring your head back to center and lift and lower with your chin. And possibly at some point even dropping your chin. You could let your head be heavy, possibly hanging out here. Or you might begin to explore some head circles, some neck circles. You could roll your head from shoulder to shoulder as one possibility. A half circle, maybe a full circle, or really anywhere in between. There's that invitation to explore some movement. You might also be pausing somewhere along the way. If there's a sensation or feeling you'd like to stay with. Possibly staying with head circles, or maybe making your way back to center and exploring some movement for your shoulders. Could also do some circling. You could bring your hands to your shoulders as an option and circle with your elbows. Maybe moving in both directions. And so however short this movement is, this movement practice here, feel free to also continue to move or adjust your body, to notice your breath if that's useful to you, as we shift gears and talk a little bit together. So again, thank you all the panelists for being here. Just want to kind of have a little bit more housekeeping. So some Zoom instructions. First of all, the panel is being recorded. So this recording will be uploaded to the film's YouTube channel, and that's available to the public. So the chat and the Q&A box contents will never be made public, so no worries about that. If you'd like to ask a question, please just go ahead and click on the Q&A box at the bottom of your screen. Questions placed in the chat box opposed to the Q&A box will most likely get lost, right? They just get lost in the flow and not be posed to the panel. Typically, we're not going to be able to answer all of the questions, but we really value sort of getting a theme that maybe is coming up, or seeing if there's something that we really need to pay attention to or that you'd like us to respond to, and we will do our best in the time that we have. So if you'd like to remain anonymous, there's a feature in the Q&A box that you can check if you'd like to ask an anonymous question. And just for privacy purposes, I won't read anyone's name when I'm relaying audience questions to the panelists. And then finally, right, so this panel is really about education, starting conversations. So we're not going to be doing any kind of professional medical advice, although we have medical professionals here. So none of the discussion is meant for medical advice, encouragement, or recommendation for anyone to reduce or withdraw their psychiatric medication or from their psychiatric medication. And of course, all of the views that are expressed of the speaker and not on the behalf of CFTE or JRI. So these are just, folks talking about kind of their reflections and impressions. And so we do want to create a space for dialogue. And so I'd like for us to just kind of dive in and join the discussion now. So I'd like to introduce folks. I'll do a brief introduction and then give our panelists an opportunity to talk a little bit more and begin to just voice some of their reflections. So our first panelist, Dr. Kerry Ann WIlliams, specializes in psychiatric management of traumatic stress and post-traumatic stress disorder, and provides supervision and psychiatric consultation to programs that are within the Justice Resource Institute, where she serves as a medical director of the Massachusetts Children's Residential Programming. Kendra Campbell, Dr. Kendra Campbell is a holistic psychiatrist, yoga teacher, and founder of Free Range Psychiatry, a nonprofit whose mission is to holistically heal and empower people living with mental health symptoms. We have Lynn Cunningham joining us, who's a co-producer and co-director of the film, and Angie Peacock, who's a former Army sergeant and subject of the film, Medicating Normal. So I'm just going to pass the floor to each panelist and give them a chance to say a little bit about themselves, and then we can start seeing what we have in the Q&A. And how do you all like, I don't even know if we talked about this. Do you prefer Dr. Campbell? Kendra, what's your preference? I think you're muted at this point, but.
Either is fine.
Okay, well, if you wouldn't mind introducing yourself, that'd be great, and sharing a bit more, and possibly integrating any reflections you might have.
Sure. So I am a holistic psychiatrist, a yoga teacher, and probably a lot of other things on that list. I founded Free Range Psychiatry, which is a nonprofit organization. We see currently patients all 100% via telepsychiatry. So we're a fully virtual organization, which is pretty cool. We have patients right now, I think, in about like 13 or so different states across the country. And we essentially really take a truly kind of holistic approach. We are as far away from, I think, conventional psychiatry as you could probably get. We do things quite differently. We use a lot of holistic interventions, including like, mind-body interventions, yoga. We also do a lot with nutrition and diet. We do therapy, multiple different types of therapy, all kinds of different things. And we kind of actually really specialize. Our patient population tends to be either people who have actually never taken a psychiatric medication before, and they just really don't want to, but they're not feeling well, and so they kind of seek us out. That's a small percentage. The large percentage of patients that we see are people that are usually on at least one psychiatric medications, many times many, and they very much want to come off or at least minimize the medications that they're on. So we help them. We kind of specialize in people who kind of already know that this is something that's not working out for them. People tend to be in different kind of stages of change when they come to us, but the general theme is they either know for sure, or they have a very sneaking suspicion that the medications are really not helping them, and many times they're making them feel significantly worse. So this is actually the second time that I have seen this film. I watched it and was lucky enough to be a panelist one other time. So, and I think it's even better the second time. I think I saw more things than I didn't even, notice the first time I watched it, but it is just, it's so powerful. I mean, literally the whole time I'm just going, yep, yep. Because just what you captured is my daily experience. Like what you captured is, it's what I see every day. Every one of those stories, I have seen a patient that had that exact story. It's so common. This is what I see all the time. So I think it was just really beautifully done. It also, I'll say that, being in this field and doing what I do, it's wonderful. I love my job so much. But of course it's challenging. And I will say too that, it does sometimes kick up some anger. Like I definitely felt that. Like there are times, especially when the end where I forgot her name, but the patient who was interviewing the psychiatrist, and he's flat out denying that, that benzodiazepine, like, it's your fault. Like, yeah, it's a little hard for me to watch that. I get a little angry when I see that because, from my perspective, I just see, I see so many psychiatrists that are behaving this way and are prescribing this way. And, of course, the patients that I see, for the most part, most of them are people that have been through many different psychiatrists, or and have had like some pretty bad experiences with a lot of psychiatrists. So just kind of seeing that is just kind of triggered some things for me where I'm like, yep, that's it. Like, this is what we're up against. I think, unfortunately, a lot of uninformed psychiatrists. So that's definitely something that came out. But yeah, very, very, very great film.
I guess I'm going next.
Yeah, I was gonna unmute myself, but then I got all scrambled. So yes, that would be lovely.
So yeah, thank you for making this film. I work primarily in child psychiatry, and watching this kind of triggered memories of doing primarily work with adults, and um, some of the practices that I've noticed from some of my colleagues and experiences that patients have reported, and things like that. I guess I'll just expand the introduction a little bit. You guys know I work with the Justice Resource Institute, JRI, and I've trained in multiple states. I've trained in Nebraska, I've trained in Rhode Island, and I'm originally from Jamaica. So if there's any Caribbean folks out there listening. And my reflections kind of on the film as I watched, it just made me think about the fact that not all psychiatrists spend time explaining things. And folks have told me that, patients have told me that, and I'm always amazed. I'm like, who's out there not explaining things to people? But turns out that quite a few psychiatrists don't take the time. And particularly giving people a chance to kind of explain how medications make them feel and to validate their experiences. It seems like it should be common sense to do that if you're prescribing a medication, that you should give people a chance to say, hey, I took this and here's how I'm feeling, and to listen to that. But it turns out that not everybody does that. And this film made me really reflect on what I would consider to be expected practice, that it's not actually happening out there. But also what it made me think about, because even earlier today, I gave a talk on what we call de-prescribing and the challenges for that, is that our system doesn't really support de-prescribing. There's a lot of things that support prescribing and not very many things that support de-prescribing. So we even reflected on the fact that there's a lot of instruction for how to titrate medications, but not a lot of science to explain how to taper people off of medications. But also even the idea of what else is out there besides medications and individual therapy. It's not covered by insurance. So how can people have holistic treatments if they can't pay for them? So there's kind of a lot of systemic issues that don't support alternatives to medications and individual, and just like regular talk therapy, that is. There's not really ways for people to access or pay for it. And there's not instruction in how to really taper people off. And most of the studies are short term. So there's just kind of a lot of things that makes me think about the challenges for reducing medications, the time spent kind of with patients, about explaining, how the medications work, and then getting the reflections back about how medications are making people feel. There's a lot of things missing, and this really made me kind of reflect on that.
Thank you so much. That's so great. I'm interested in that language of de-prescribing as well. And maybe we can elaborate on that more. Lynn, if you'd like to just introduce yourself and maybe share a little bit, there's some questions coming in the chat about what drove you to do this film. I think folks are curious to hear a little bit about that. I think you're muted though.
Thank you, JRI, for screening Medicating Normal, and thank you, Jen and Dave and Dinah, for all of your support, and to my fellow panelists for their expertise and for putting all of this into context. Based on feedback from a recent Yale psychiatrist who screened Medicating Normal at a Yale Grand Rounds, I just decided today to give a little bit more context. Not totally in detail about why I made it, but it began for me as a very personal quest to help a suffering family member, a suffering, very heavily medicated family member. And after about 3 years of research into the drugs she was taking and why, it became a mission to tell an untold story. So this particular untold story is not the only one. I just want everyone to know out there that defines mental health care. And as angry as we all got making the film, and as unfair as it is, in the rollout of the film, many, many people do come up and say, you guys, my meds have really, really helped me. So I want that to get out there right away, that it's not the only story, but it is an untold story. And its absence, the absence of this story from mainstream medical messaging was why we thought it was so vital to share the story. There are many excellent psychiatrists and psychologists, as evidenced by our panelists and our experts in the film. And there are drugs that do provide effective symptomatic relief. But in the making of the film, we discovered a parallel truth that is really a really big one. And we just couldn't figure out why it was not out there being told. So the film took more than 6 years to make, about 3 years of research and 3 years of production and editing. And we're now in the outreach phase, and which we find incredibly, many films kind of end when the film is made. This, in a way, began after the film ended. And what we're calling the outreach phase, this is our 134th community screening with unbelievable organizations around the country, nonprofits, people who have similar goals, people who have very little knowledge about the subject matter. And every single time we show it to an audience, we get great questions. We learn more ourselves. We just meet, it's as if we're building a coalition of great healthcare providers, allies, doctors, friends. So it's been an incredible journey. And I can go more into detail about why it was made, but I think let's hear from Angie and we can come back to it. Thank you for being here.
Hi, everybody. I'm Angie. You saw part of my story in the film. I'm now 5 years, 3 months off of all medication. Never what I really intended to do. I was just taking like a harm reduction approach, but it just happened that way. I still suffer from some pretty severe neurological symptoms that are from the long-term impact of taking multiple medications over a decade. I did go to social work school. I graduated with a master's in social work. I did an internship as an outpatient therapist, so I learned how to be a trauma therapist. I did 1 full year of somatic experiencing. For multiple reasons, I decided not to practice. So this is kind of my social work, where I'm doing all these panels and talking about all these issues and the nuances. And I think I really appreciate my experience to be on the lived experience side and a little bit on the clinician side, so I can kind of walk the line and communicate between both sides. So I just look forward to all your questions and excited to be here. Thank you.
Great. And I think there's a lot of folks that are just really resonating and appreciating you sharing your story too, Angie, which I suspect comes up a lot, but I'm feeling that as well, because there's a lot of vulnerability in that. And so I really appreciate you putting that forward. So one of the things that I was sort of hoping we can frame our discussion around, and then we can sort of see what some of the questions are that come in, but is really thinking about some of these structures of the pharmaceutical industry, or psychiatry as a whole, and the power dynamics that are in play. We see this a lot, I think, in care in general, whether that's the therapeutic relationship between the therapist and the client, the doctor and the patient, and people begin to lose their voice, or they're not encouraged to use their voice actually and share, like, Dr. Williams is saying, Dr. Campbell, about like, what it is that they're feeling in their body or they're noticing. And I wondered, what are ways that you try to do that, either repair or empower clients to have a voice and to use their voice? And of course, Angie and Lynn, if you have reflections on kind of any of this and what you observed in the making of the film or your firsthand experience, like, please chime in. But I would be curious to hear a bit about that, and then we can see where that takes us. Anyone can dive in if that's all right.
I guess I'll start. So, in my practice, particularly in working with kids, I see a lot of teenagers. And so I see a lot of first time presentations of things. And when someone is, well, I guess the term we use is medication naive, is you have to kind of tread carefully, because what you don't know is how their body is going to interact with the medication. I think there's some physicians that are, I think, maybe overconfident in the role of medications. But I guess I've seen enough cases where medications have been both helpful and unhelpful. to kind of take the approach where I will ask explain the risks and the benefits, and explain to them that if you experience a side effect, here's what you're going to do about it. And I think that's really helpful for folks to know if they're getting kind of information about something, is here's how it could help you, here are the potential risks. And if you do experience the side effects, here's what you need to do about it. Here's what's reversible, here's what's irreversible. And if you here's what you do, call me for this. Don't stop something abruptly, kind of just give that information. But if someone starts something and they come back and they say, here's how I'm feeling, I'll say, well, there's two options. It could be your body getting used to the medication, or it could be that you are, this medication is not working well for you. What would you like to do? Would you like to give it more time to see whether it is an adjustment? Would you like to stop it? Does it make you feel uncomfortable to take it? And kind of putting that decision back in the patient's hand, because, if they're not comfortable, continuing, then it should be stopped. So I guess that's how I think about it. But then also there's the idea of invalidating somebody's side effect. So for example, in the film, the young woman experienced hallucinations, which is not is not something that I commonly see. But if someone came to me and said, I didn't have hallucinations before, and after starting the medications, I suddenly have them, even if it's not common, I would say, it sounds like you're uncomfortable continuing this medication. Would you like to discontinue it? Let's see what we can do next. Because I don't know everything. And even the drug companies, when they've done these studies, there might be side effects that they've missed. And so there's, I think, a little bit of a humility that needs to occur when we're practicing medicine. It's something I was humbled a long time ago when I saw how many people were not benefiting from medications. So I think there's a humility that I approach my practice with when I work with patients, knowing that I don't know everything, but let me help you on your journey in ways that for the information that I do have. And if you experience something, share it with me and we'll talk about what to do next.
I love that. I hear curiosity in that too, actually, a curiosity around how each person is different and unique, even though you have expertise and there's trends and patterns. It's sort of like, okay, but how is this for you?
Yeah, exactly.
I love that. Yeah, Dr. Campbell, do you have stuff you want to you got to unmute? I think that you got it. There you go.
I do, yeah. So thank you. I agree so much with all of that, especially the humility. I would say I probably maybe even go even a little bit further. I kind of, it's my belief that that symptoms, whether they be anxiety, insomnia, or whatever, are actually, an indicator that something in the body is out of balance, right? Something is not going well. So being able to recognize that symptom and recognize that there's something going on, and then kind of understand that you can actually have like a lot of control, that you yourself, that the so-called patient, actually, there's a lot that can be done. I recently wrote this blog post called like, don't ask your doctor, because it's kind of like, in my opinion, we grow up in this society where, as kids, they know what's going on in their body, right? Like they understand, and they're in their body, and they got it, and they know what's going on, and they're very cued into everything, right? But I feel like we, as parents, I'm a parent, so I know, we say, no, don't trust your body, trust me. I'm the parent, I'm the authority. And then the same thing happens with doctors. It's this, the doctors are the authority over your body, right? And I just don't believe that. I think that my whole thing is giving the power back to the patient, and empowering them to say, hey, this is your life, this is your body, and you are the expert. Like, I'm never going to be the expert. Never, ever. I always take the approach that I probably know very little. You've been in your body your entire life. I've known you for 20 minutes. Like I'm not the authority. And so I think for me, that's probably one of the things that I do from like the very first visit, is just talking to them about that. And of course, I think it can be a little frightening for some people. I think, it could be a little bit scary, because it's like, wait, no, especially for people who've been in the system for a long time, and they've seen many psychiatrists who know those are the authority, right? And to be told by another psychiatrist, like, no, I'm not the authority, it's actually been you all along. I think for some people it could be a huge relief, and some people are like, wait, no, I wasn't ready to have authority. I'm not ready to be in the driver's seat here. I'm used to, like, you just tell me what to do. I don't like this. So it's kind of interesting working with people, but that's definitely my approach, because the way that I see really just the whole medical system, and definitely kind of psychiatry is this very much, it has grown into this, like, they're the experts and we're just supposed to blindly, trust. And people do that. And this came out in the film. And this is what so many of my patients, I actually just did this really cool little mini documentary, not anywhere as cool as this one, with a patient who was sharing her story. But there was the same thing where it was like, she just assumed, you just assume that if somebody calls himself doctor, if someone's wearing a white coat or whatever, like they are the authority. People, we put our blind faith that how they must know, they're a doctor, they went to medical school, I have to trust them. And so I think it's just that it's a part of our culture. So for me, kind of addressing that, helping to kind of change this again and really put the power, back with the patient, to me is really, really important and a big goal.
I'll try to keep it short, but you both said such good stuff. God, I could hardly add to it. The only thing I want to add is from the patient's perspective, or what happened to me was that my side effects were mistaken for another mental illness. So it is a very slippery slope that, you start off with post-traumatic stress, which is our own, our evolutionary, I don't even think it's a disorder. It's like, when I look back, I'm like, the way that my body reacted to that was normal. Doesn't mean I wasn't suffering. It just means my body was keeping me alive. It was doing what it's designed to do. We're hardwired for survival. So the trauma can come in many forms. People compare to me like, oh, I wasn't in a war. It's not about what kind of trauma. It's just the trauma itself, right? So, but then it turns into like, okay, but now I'm depressed and now I have headaches and now I have sexual dysfunction. And now it's like, well, that's your trauma. That's your depression. Now we need more medications. And then you turn into where you saw me in the film where I'm on it was actually 18, not 17 at the same time. And when you're on that many medications, you have no autonomy. I had no control over my life. I'm literally collecting a disability check, living in a $400 a month apartment with no lease. Nobody's looking after me. I have no social life, no partnerships. I mean, I literally, it's all over my medical records that I was seriously mentally ill, chronic and severe, never going to get better, taking medications for the rest of my life. Okay. But that was not really my mental illness. That was the impact of multiple medications and me losing my autonomy, So what's the answer to empowering patients? I think the other thing really is, and I'm sure you're going to talk about this in a minute, but there was something in me that kept saying like, something is not right. Like, you don't feel good. You were not like this. I was a soldier with more awards than my commanders. And I went from that to sitting in an apartment, reading books, trying to help myself and smoking cigarettes and being 230 pounds, like within a year. Like, that's not mental illness. And for us to think that that is, I mean, we're conflating some things there,
I love what you're saying there. And Lynn, if you have more you want to weigh in too. And I just want to chime in that I really resonate with this idea too, that like it's an adaptive response to a circumstance. So much of the manifestation we see of mental illness is manifestation or sort of like a response to trauma, to things that are traumatic, that are overwhelming to our system, and then we pathologize it, right? And so then and finding that line is I mean, it's so brilliant the way the film lays that out around comfort and the magic bullet. So Lynn, did you have some thoughts you wanted to add? Yeah, I'd love to hear.
Well, I just want to say, as a family member, looking way back, we as family members, you're scared. We relinquish all power. We did back then, maybe more. If we come into contact with Dr. Williams or Dr. Campbell, it might have been a totally different thing, but it was a while ago, and we relinquished all power to psychiatrists, very good ones, very well-reputed ones. And we believed 100% that what they were telling us about that she had a chemical imbalance that would be, that would last a lifetime, that medication could help right it. We believed that that was scientifically, based and true, and now it is untrue. Now it is not proven. And I just feel that, I feel as if people have to start to question the actual science. And it isn't just that patients or their families do, it's medical students need to. And we met, I think it was 2 days ago, we had a wonderful screening with Worcester Withdrawal Group in England. And all of a sudden an American medical school student popped up with a question. It was a small screening, so it was nice. And he just said, listen, I am curious about all this. I am not getting this. My med school, which I think was somewhere in North Carolina, does give me the basics, but it doesn't tell me really, it does not go into any depth about what withdrawal is. There are no studies that are presented to us. And we're not giving our young doctors in training the tools they need, I think, to really understand the science. So that's one thing. And but this whole notion of the power, what got us so upset when we first met Angie and the subjects in the film, the rest of them too, is that in every single case they tried to explain the way Kerry Ann is saying. They tried to explain to their doctors and they just weren't believed. No one took them seriously. No one listened to them. And you heard that. And I don't think that's so uncommon today. I think that happens all the time. And my Yale friend said, well, Lynn, it definitely doesn't happen here at Yale. And I was like, I doubt it happens at Yale. But, you know, we have a huge country with many different levels of care. And I just think, so the internet it doesn't do all good things, but I think in this case of psychiatry, these wonderful support groups where people can meet other people who have been diagnosed with similar issues or who are taking the same drugs or who are trying to get off of these drugs, they all meet each other. And it used to be that people were siloed, I think, stigmatized, siloed. It was a one-on-one relationship with a psychiatrist who not at all like ours here today. And it was scary and it was embarrassing and all the power. There was no power. I think it's shifting today and the internet is really helping us. And anyway, so I think change is in the air.
I just want to acknowledge too, there's a lot of energy in the questions in the chat around that advocacy and change. And I would just encourage folks to participate in this conversation and just let this settle, and that may lead us all in different directions in terms of then what's next. But I wondered if we might talk a little bit about some of the, I think, well, I mean, I resonate with this, what you all are sharing about how you can offer someone power and agency, but it is turning that relationship on its head that folks are used to of like, and I feel this as a therapist as well. It's like, you're not going to give me advice. It's like, well, I mean, I could, but like, let's actually think what you want, what is it that you are seeking and what is it that you need? And, and that takes more time and that takes patience, and systems around us aren't always designed for that as well. Right. And so I really appreciate probably the streak of advocacy in each one of you because of that, right? Having to push back against those systems. And so I wondered if we might shift also and just talk a little bit about the ways in your experience that psychiatric medication psychiatric medication can impact our sense of self or our capacity to feel our own self. If we're sort of asking folks to report on what they're feeling, but maybe there's ways in which we begin to become numbed or deadened to what we feel, or, what are the impacts and how do you work with folks around that? I'm curious or what's your firsthand experience? Super curious about that. Anyone can dive in.
I'll say, so that comes up with every single one of my patients. This is the theme. Of course, like I recognize too that I have a little bit of a biased sample, like, with the patients that come to my practice, but yes, 100% of them, when they're on medications, there's something that Dr. Peter Breggin actually calls spellbinding too, by the way, which is where when you take a medication, it actually causes the inability to appreciate kind of what's going on in your life. So you may say, oh, I'm on this medication and I feel okay, but everyone else is looking at you going, no, you're not doing so great. And that's actually the medication that can be causing that. But I have heard from thousands, I would say probably at this point, of patients who have told me that medications, and this includes all classes of psychiatric medications and actually some non-psychiatric medications, can cause significant levels of feeling just really disconnected, zombified, out of touch, like really like there is this just wall between you and everything else. Like you just literally can't access that you portion of yourself, right? I hear it again and again and again. And what's interesting in my work is that I get to work with people as we're coming off the medication. What I have heard from every single patient who is coming off of them have told me, this is really bizarre. Like the experience is so strange because it's almost like they will tell me that they really did forget who they were, right? Like the whole time that they were on medications, it's almost like this period of amnesia. And as they're slowly coming out of it, it's almost like coming out of a coma and just being like, oh my gosh, like, what's going on? It's just this like very strange feeling of not even knowing who they are, what's going on. And it can be actually one of the most challenging things about that process, in my opinion, is that experience that is scary. And it's kind of like, well, if I wasn't me all those years, who was I? Like, who was the person that was walking around in my body and doing those things? Like, what things did I do? What things did I do that maybe I wouldn't have done if I hadn't been on medication? Like, who am I now? It's just really can be a traumatic process in and of itself, going through that experience. It can also be quite amazing, and I love being a part of it with people and helping them discover like who they really are and what they really enjoy doing. Like, it's beautiful, but of course it can also be kind of a frightening experience for them.
I just wanted to also make a comment, and I always told the kids that I work with that feeling is a part of being alive. Experiencing emotion means you're alive. Crying is one of the first signs when you're born that you're alive. And so if I start, an antidepressant and they come back to me and say, I'm not sad, but I don't feel anything, I tell them that's not what the intention is. The medication isn't doing what it's supposed to be doing. And you're not supposed to feel numb, so you need to come off of it. And I think maybe there might be some folks that maybe there's a lack of recognizing when people are starting to become numb on medications, because it can sometimes happen right away. There's certain medications you started, and if it's not actually having the intended effect or, that sort of thing, they should kind of quickly change it or discontinue it. It should be recognized. But I'm thinking back to something Angie said, which is sometimes when people are having side effects, it gets misinterpreted as more mental health symptoms. And they think, you're not feeling numb. Oh, we need a higher dose of the medication. And so this kind of sense of like, wait a second, are you sure? Because this actually wasn't present before I started the medication. Being able to sort that out, that takes time. And our system doesn't support physicians spending time with clients. If you only have 20 minutes, you don't have time to sort that out. And so, I was trying to think about, how medications affect the way we feel in our bodies, and if there's a positive effect. And I had more examples of kind of negative effects. I mean, benzodiazepines, I pretty much never prescribe because there's so many examples of people feeling disconnected from their bodies with benzodiazepines. It actually makes it easier to dissociate if you are struggling with trauma when you take benzodiazepines. So at this point, it's considered relatively contraindicated for people experiencing trauma. It really shouldn't be prescribed, unless there's kind of no other option. And if so, only short term. So benzodiazepines are a number one culprit for making people feel disconnected from their bodies. And then there's other meds that will cause a feeling of numbness. And then the last thing I wanted to say is there are times when, there's an indication that a person no longer needs a medication and it gets missed. So for example, for kids, they may come to me with anxiety, and I start them on something that's helping them with anxiety, but their anxiety actually improves with therapy. And now the medication is making them tired. And that's because they no longer need the medication. And I might think, oh, they're tired. What's going on? Do they need something to kind of perk them up? No, it's because they no longer need the anxiety medication. They're improving with therapy now. You can start to peel off the anxiety medication. So kind of recognizing when people are improving and maybe what they're experiencing is over medication and they need to kind of peel back, is sometimes it goes missed.
I'll say a couple things about, I was thinking about this before the panel, because that's such a good question about, like looking back on my own experience, how did the medications impair my ability to feel my body, those sensations? And when I thought of that, I had this little mini flashback of, I took a biofeedback class And they put the little thing on her fingers and everybody's sitting in a circle. It was at a VA hospital or something. And then she said, you know, close your eyes or look down. And the minute I was supposed to look in, I just completely panicked. And like, I couldn't sit with myself at all. And they basically kicked me out of the class and said, you have, what was it? Relaxation induced anxiety, whatever that is. But I just want to illustrate the point that, okay, I went through a traumatic experience. I came back and the help that I received was a medication. It wasn't skills. It wasn't, let's sit with your body. What's going on in there? It wasn't validation of what you've been through was really scary. You're going to feel like crap for a long time. So when you put that medication right away and you don't have skills or coping or friendship or support, it kind of robs your ability of dealing with life, you know. And so much of what Dr. Campbell said is like exactly what I'm experiencing. You know, I'm 5 years off and I'm looking back at my life, like whose life was that? I was not in it. And we always talk about, you know, like drugs work. What do we mean by they work? Like they work because I was so numb, I didn't care about my trauma. You know, we say that that's how they work. And some people want that effect, which is fine. I mean, for a time, I wanted that effect. I didn't want to feel anything. But we're not clear about that's what we mean by they work. I mean, what does that mean? They work, you know? So I've met a lot of people in the screenings that say, I have to take them or I will kill myself, because that their ability to contain the feelings and the life that they're given or living with is too much. And they like that effect, and that's their choice, you know, but there's no informed consent about that. You know what I mean? And then getting off, but so then getting off, I'm waking up from this nightmare, you know what I mean? Like, what just happened to my life? I kind of said that in the film, and we call it like this reintegration process, you know, like you have to, like, your brain is literally rewiring itself, because like the drug is gone and now you have to learn how to live life again. And especially when you're like as disabled as I was and like not functioning, no friendships, like I haven't dated in 15 years because like that part of my psyche was taken from me, you know? So I have to learn sexuality and femininity and what do I even like and what is the world like? And I'm interested in people again. I wasn't interested in that. And there's not really a mental health professional I can go to that can help me with that. Like, to say I was harmed by a system that I thought was going to help me, and now I'm like trying to figure life out. It's really hard.
I guess I think about systemic trauma. I mean, that's what, you know, I think people have been sort of chatting about this as well. It's like, what, you know, is there a secondary trauma that happens from? Absolutely. I mean, to me, that's what so much of the film is about. I'm curious too, Lynn, there are just a little, a kind of a thread of things that are coming up in the questions around, or, you know, Angie too, about, you know, for example, you know, has the APA responded to this? Have they seen this? You know, what about like, were pharmaceutical companies, you know, contacted for the film? So just kind of, I think folks are curious about the bigger systems and if they're seeing this or if conversations are happening.
Well, I feel that our
mute, Lynn.
Thank you.
Your mute is on.
Oh no, we got you.
Oh, did you get me?
There you go.
Yep.
Not yet. The AAP, it has not seen it yet. I feel our recent screening at Yale Grand Rounds was a big deal for us. I was really nervous about it, and there's an absolutely wonderful psychiatrist there, and he's older, so you know, he's in that, he could have been one of the ones that my family consulted with way back when. He doesn't, but he's open-minded, he listens, he loves the film, he prescribes, but he feels that it has to be shown to every medical student at Yale. And he wasn't allowed to we weren't allowed to be there because these things are very private and confidential. And I was just dying to know how it was received, because that to me is, you know, the epitome of being accepted in the mainstream. And he said, I can't tell you, all I can tell you is that they talked about it for an hour and 40 minutes, so that it is, so, and we love that on our team, because that, it doesn't even matter if it's being talked about, it's important. And just being thought about. And okay, so maybe I didn't get the feeling that they all loved it. I got the feeling, and he couldn't tell me this, so it's not fair to really report on it, but that they felt that it wasn't a balanced picture of psychiatry today. and that there are, you know, certainly, and again, this wasn't said to me, but this is what I gleaned, that at Yale, for instance, they spend so much more time with patients, and there are very good doctors who combine therapy and meds, and this is really important to distinguish. And, you know, the doctors in our film did not give enough time, clearly, and they happen to be our subjects' doctors. But I think there is going to be a defensiveness and a feeling like, well, but I'm a great doctor, and that's not fair. There are great doctors. So, but what I said to him, and what I think is so important, is that it would be so, there is care that is subpar that's going on. And don't you guys at Yale want to know what else is happening out there? It's not that, you know, we're in a little ivory tower and this is all it is. We need to worry about our entire country. We need to worry about vulnerable groups. Foster care is heavily over medicated. The veterans are heavily over medicated. You go on campuses around the country. 9 out of 10 of my son's friends, he's a senior, are medicated. So it is a massive issue that is way beyond. We just need to look at it and think to ourselves, are we doing the right thing? But no, we're not out there yet, and we want so much to be on a PBS type show. And I'm hoping that we can convince PBS that if we present a panel like this one, we're not trying to villainize anybody, we're just trying to truly talk about it, that it will be a way to get it to a more mainstream audience. But as of now, it really isn't. But then, and as we've been showing it in these screenings, we have not gotten huge pushback either. People have been very supportive. So
yeah, and this kind of goes off that other question that you asked before about like, how do we empower people? I did like a fellowship that was like a legislative policy fellowship in Washington, D.C. And I did all these really fancy research papers, and I brought all my evidence, and I went and talked to all these lawmakers in their office and chased them around, you know, all that stuff. And it was like I was speaking a foreign language, because the systems believe that if we throw money at mental health, it's going to make everything better. If we restrict gun rights for mentally ill people, it's going to make everything better. If you call the police on someone having a crisis, they're magically going to be swept away and they heal overnight. And like all these things, that's the narrative, you know what I mean? That we all kind of believe. So I kind of gave up on the systemic change. I'm so sorry, but my energy is better spent in audiences like this, where there's 100 people in the audience. Everybody hears it. You might take one thing. It might be even subconscious that you don't even realize that you heard us say, and it changed something within you. And you might tell someone else. And to me, that's where the change is going to happen, because as people become more informed about their own bodily choices and I'm not saying to not ever take a med again, like that's up to you. Just to like maybe read the pamphlet or ask the pharmacist or ask the doctor, like, how long am I supposed to take this? What happens if I want to get pregnant? Like these questions that we don't even ask. To me, that's where the change is going to happen. And then as far as pushback goes, I have noticed a little bit, but like therapists seem to be very open to this because they see it. You know, they see a client once a week for an hour, they can see change. Often they'll say, I can't tell if I'm treating the original problem or if I'm treating a side effect, because it's so confusing. It's confusing to all of us. We don't even know, like, really, what are these medications doing? Other places, this has been a very interesting phenomenon. Like, I'm going to be very vague to keep them anonymous, but like 2 states, their disability rights activists, like the state level, you know, screened the film. And then they had a conversation, and one of us listened in a little bit, and they kind of said like, oh my God, are we like pushing treatment on people? Like, should we be doing that to disabled people? We're like making them go, you know what I mean? Treatment courts, that's another problem. We're telling people you're gonna have a felony if you do not participate in treatment. Like, these are human rights issues. You know what I'm saying? This is not just take a medication and go back to school and sit still. Like, these are far reaching. Getting a diagnosis follows a child for the rest of their lives. It impacts your life insurance. It impacts your ability to, you know, join the military, like get a security clearance, like all these things. So it's not just, you know, do I want to take a medication? There's so many intersections here. I just wanted to call attention to.
Well, it's interesting what Angie brings up. I think change is going to happen. I'm very optimistic about it because I see it, and I see doctors, and we've had, and the editing team, we always had these, do we want to make this film? Do we want to preach the choir, or do we want to inform people who know nothing about the subject? Do we want to change people's minds or be supportive for, so we want to do it all. And I think it can be done from top down and grassroots up. I really do believe. And I think I have great faith in doctors out there who don't necessarily see it the way we do right now. I have great faith. I don't think they've been exposed to someone like Angie telling her story yet. They will be, but I really believe like someone like Anna Lemke is a really good doctor. She started out very mainstream and very traditional and very by the book. And she started to listen and learn, and then did a U-turn in her own practice. And I just think that happens and will be happening more and more. And well, we just have to, ask questions and talk to our doctors. And well, Angie has a great thing about a little list about, how to find a good doctor. And it's fascinating. It's, ask about an exit plan. So, okay, these meds really help me now and I need them, but am I going to come off of them, and when? Sort of like what Dr. Williams was saying. When will I know that symptom? Anyway, Angie, you take it over.
Mom's there. Oh no, I just say the thing I always say, and I think some people in the chat ask too, like, I always say to ask your doctor, like, what do you know about antidepressant withdrawal? Or what do you know about, how do I get off of this? How do we taper when it's time? And then shut up. Like, don't tell them what you think that they should know. Let them answer it for you, because the way that they answer will tell you a lot. Like if they say, oh, we can get you off, no problem, you'll be off in 2 weeks, you should probably run. If they say something like what Kendra would say is, we will take as long as it takes. It's up to you. We will listen to your body and it's in your court. That is a doctor to hang on to for dear life, because I can't tell you how many emails we get every single day. I just got one today about, there's a man in Texas who's experiencing psychosis and he doesn't want to go to hospital and he's already on antipsychotics. And what do we do? And it's like, I have no one to send you to. And especially not anybody that accepts your insurance, which is a freaking crime against humanity. You know what I mean?
Agreed. That's so true. I am so resonating to this idea that when you're in a position of being a psychiatrist, right, and maybe a really thoughtful, respectful one, somebody who's doing the work really well, and how that does feel like you're going to get defensive or feel protective of your. But I think it's so important for us in our various roles. Same thing as a therapist or a yoga teacher, right? People abuse those power roles all of the time, and whether it comes from some kind of benevolence or something that is darker than that, right? But that happens, that coercion happens. And I think the more that we can name it and feel comfortable with it in terms of a truth, then we get to have these kinds of conversations and do it differently. But it is really interesting as reflecting on, we get in our bubble. I see that at JRI, right? We're like in this trauma-informed bubble. It's like, right, not everyone thinks about trauma this way. Like this is an outlier. And so when we go have these conversations, we could be making a lot of assumptions that we need to check about how people understand this and think about it. I wondered, I had one more and then we'll start to move toward a wrap up, but we have a little bit more time. One thing that you said that I thought was so profound, Dr. Williams, is feeling is being alive, right? And so how do you think about this line of, what is normative feeling? What is when feeling is too much? Like, how do you have those conversations? And I wondered too, Dr. Campbell as well, but if you want to start us out, Dr. Williams, that'd be great.
Yeah, it goes back to like what the film said about medicating normal, like how much of this is kind of an expected response to things. And so when I practice, in many ways, I rely on the client, the family, to let me know what kind of their definition of suffering. How much is too much? How much can you manage? So for example, I may have someone on a particular medication dose. They come and they talk about how they're feeling and what they're experiencing. And I say, well, here's the option. If you feel like you would like to continue working with your therapist and continue processing your emotions and talking about this, we can keep the dose the same. If you feel like it's unmanageable and you'd like to increase the dose, we can increase it. What option would you like? So it's so difficult for me to be able to determine what someone's kind of threshold is for, you know, what they're feeling versus what is something that needs to be treated. It's something that I kind of have to rely on them for, but it's also very difficult with trauma, right? How do you put into words what you're feeling in your body? And so that kind of just leads me to think about the fact that they never really taught me in medical school about the fact that trauma is held in the body. It sounds really, I mean, like, we're in this JRI bubble, you know, it's like, it makes so much sense, right? But they teach you the medical model. They teach you how to treat symptoms. And so this idea that, wait a second, you can do all these other alternative treatments. You can, you know, for trauma, you know, all these things that target the body at the level of the body, you know, yoga and things like that. It's like, you know, nobody kind of says to patients, you know, you can do medications, therapy, or these array of other alternative treatments that are body, you know, help to connect your mind to your body. Nobody talks to patients about that, and it's not available to all people. So, you know, I would say that I talk to patients about feelings. I let them describe how they're feeling. I let them define how much is too much. And I feel, I feel very limited in my ability sometimes to help because I can't offer all the different things that I know could be helpful for them in terms of non-pharmaceutical kind of things.
Yeah, I just wanted to say, yes, I totally agree, you know, with that approach, that, you know, it's very, like, again, I'm, like I said, I'm not the expert. I don't know someone's body or what's normal or not to them. But I will say that a lot of what I do is because education and like normalization around these things, right? Because, like, for example, you know, 99% of people that come in say, I'm broken, right? That's the phrase that I hear over and over again. I'm broken, I'm broken, I'm broken. And then, you know, when I start talking about it and breaking it down, I'm like, actually, you know, we can actually see that, you know, you had this trauma and then this happened to your body and this happened, blah, blah, blah. And now we're here. So it looks to me like your body actually is doing exactly what it's supposed to do, right? Like your body, you should feel anxious right now. You should not be able to sleep. You should feel depressed because all of these things happen and they were never addressed. They were never treated. So there is nothing broken about you. It's you are functioning exactly the way that you're supposed to, you know. So for me, it's a lot of just kind of reassuring people of that, and also, you know, for me too, a lot of just providing like hope, and that there are so many other options. Like, I mean, that's the great thing about the work that I do, because a lot of the interventions that I do with people have never heard of that. So they're like, oh wait, instead of taking a pill, I can like do this weird breath stuff and like take this whatever. And I'm like, yeah, we have like tons of options. And so it's just amazing, right? Like they're just so excited because they never knew that they had those options. And so I think that changes too, like a person's threshold, right? Because you could be like, yes, I can't take this anymore. This is too much. But wait, yeah, if you say that I can do this thing, and again, talking about informed choice, right? So I say, you know, you can try all these things and they're like virtually side effect free, most of the things that I do, right? The side effect is that they also help your physical body, right? You're probably going to lose weight, your blood pressure is going to go down, and you're going to sleep better. That's the side effects of the things that I do versus this other, you know, type of treatment. So giving them those options and letting them really understand what the options are, like, again, coming back to that kind of, you know, empowerment piece.
So we could kind of do a wrap up. I don't know if we have time for one more, I feel like a couple minutes.
Okay. That's okay.
I mean, I guess I had a change question about, you know, if there were a change that you could wave a wand to do, you know, just to think and to think big, right? In psychiatry, either in research or practice, that would support the agency and empowerment of the client's experience, what would that change be?
Well, I was just going to say, you know, knowing what I know now about how the body experiences basically everything that people present with: sadness, anxiety, anger, I wish that there was maybe a more concerted effort to teach things in this way when it's presented, even in medical training, that it's a whole body experience. Because even thinking about, this question about how medications affect the way the body experience. Initially, I was kind of like, I was not taught to think that way. How do medications affect how you feel in your body? You're taught to think about how it affects your mind and how it affects kind of chemicals in the brain. And so I think one thing I would love is to kind of integrate that into teaching, is that kind of maybe holistic model of how people experience their emotions. But then on top of that, I really wish, I think, kind of the larger thing, in terms of how mental health care is even thought about, is that I realize it loses money unless people crunch 10 or 20-minute appointments. There's no way for clinics to make money unless, psychiatrists are seeing people after 15 minutes, which kind of course, compromises their care. And then there's a lot of pressure to prescribe to solve problems that can't be solved by medication. So we talk about, Lynn talks about foster care and overprescribing in foster care. And, there's kind of a pressure to say, well, we need to keep kids at this lower level of care. Can you prescribe something to make the aggression go away? And it's like, well, what's causing the aggression? Do they need family therapy? Do they need something else? There's a lot of pressure to kind of say, let's just use a medication to solve a problem that can't be solved by meds. So I really wish that there was more in place to kind of offer people non-pharmaceutical solutions, in addition to, of course, access to psychiatry and all these things that we have now, but more access to other ways of actually treating the body. I mean, I'm talking about just simple things: music therapy, art therapy, drama therapy, equine therapy. These things are they're out of touch for the average person because you have to pay out of pocket for them, So it's heals the body, So that would be what I would change, is access to some of these things, as well as changing in how it's taught.
I love her answer, because I totally agree with that. In teaching skills for children to learn, this is an emotion, this is energy. What do I do with that energy? But I also want to share a story about something that happened to me recently. My beloved service dog of 13 years just died. And going through that experience, I mean, I was like taken to my knees. Do you know what I'm saying? It was pure grief. It's the closest being to me ever. He was with me through this whole experience of withdrawal, of suicidal, of in and out of the hospital, like all these things. That dog was here for me, like no human being ever has been. Okay. So this is what I learned in that experience. A mental health professional did not help me through that. It was my friends. It was these people showing up for me and saying, Angie, or how are you doing? Do you want to cry? It was me feeling those feelings and being okay with it. Like I didn't, in like kind of what we've been talking about, like it was in my body. Like I never experienced a loss like that literally made me physically ill. Like I didn't even know it was going to be that bad. And I was like, wow, this is why people take medications, because it's so overwhelming. I can't even hold it. Luckily I have a flexible job situation that I could take time off and lay in bed. We don't allow that in our community, but so what I want to say is that human connection and love is what it is. And I know that seems like such a simple answer, but I'm really, really worried about this professionalization of help. Like anytime you have a problem, you got to go see a professional. And here's a 1-800 number. And, oh, I can't help you. Go see a professional. Like we all have skills of listening and being humans and hugging and supporting and just being real and being vulnerable and being in the hole when somebody else is in the hole. That is me. That would be my change, number one.
I would put some distance between those who conduct the studies on these drugs and those who profit from them. I mean, I just think that's a no-brainer, and that's a massive systemic thing, I know, but it just doesn't make sense to me. And I think also education, as Angie, everyone here has mentioned, just we need to empower ourselves by reading, by learning. And our family didn't read anything before our beloved went through what she went through. Just the material is out there and the books are out there, just dig in. And another thing, I just wanted to mention that there are heroic, creative people, all of you guys on our panel. There's a doctor in, now she's in the Upper Peninsula of Michigan. She started out in Detroit. She moved up there. She's a pediatric psychiatrist, integrative psychiatrist. She inherited 75 kids, 100 kids who were all taking antipsychotics. We're all on antipsychotics. She sent me a text. You won't believe it. She is slowly, and this group does not have disposable income. And this group, she talked with all of the parents and said, look, there are ways, and all of this was behavioral. These kids were not behaving in school. And she figured out that there was a dollar store down the road that had magnesium, which is basically a nice magnesium bubble bath at night, might help reduce anxiety and help the kids get to bed. Anyway, these thoughtful, not terribly expensive, creative approaches. And she's a psychiatrist. She still saw her patients, but she really believed that she needed to give these parents tools and confidence to go perhaps a different way. Now, there may be some kids that need those antipsychotics, but she got an awful lot of them off of them, and she feels really good about it. And I really believe that change will happen with creativity like this and listening to your patients, as these guys have said. So those are some of the solutions.
It's hard to come up with anything after all of you. So each one of you have kind of touched on something. Also, it's bad to ask me to give me a magic wand because I ask for a lot when I go big. So I think I kind of lead on to what Angie said, like and this would not be good for my bank account, but I would love there not to be psychiatry. Honestly, I actually don't think really hypothetically that we need psychiatrists. And I always joke with all of my patients, like when I start with them, that like, if I'm doing my job right, I'm going to make myself obsolete, and you certainly aren't going to need me. Like if I'm really doing what I need to be doing here. So I would love to start, way back at the beginning of this. And, the theme that's we've talked about is disconnection, right? We've been talking about disconnection from our bodies, our mind from our bodies, which is huge and important, but also we're disconnected from each other. We're disconnected from the planet. We are disconnected in every possible way that you can think of being disconnected. We are. That is what our society. And I mean, it's my belief that rather than say that something is depression, to me, it's some level of disconnection and trauma is usually how I describe it. Those are probably the two closest words to do it. So I would say, yeah, if we could go start at the grassroots and just fix these core kind of issues that are feeding everything, I think that would probably be my dream. And again, and I really don't think that we would really even need a field like psychiatry, which in my mind, in many ways, doesn't really makes sense. Like when you actually think about the mechanism, when you think about how mental illness or mental health symptoms like actually come to be, the path of it, to think about it from a perspective of a psychiatrist, like it actually doesn't necessarily make any sense, right? Too, like why would you intervene at that level? We know that like by the time you're having hallucinations, by the time you're having anxiety and panic attacks, something's been going wrong for a while. Your body has not been doing well for a really long time. So how about instead of waiting until we get to that point, like we do something way, way, way before it ever gets there. So I think that would be my wish. But on top of that too, if I had to have one more, if my magic wand could give me a little bit more, it would also be the education piece. It would be the it's like screaming from all of the mountaintops, which is what I'm kind of trying to do. Part of the mission of our organization is like public health, public awareness and education. We started a fellowship for psychiatrists and other folks, like to train them on these things and help bring this awareness to the world. So until we can become obsolete, at least let's be a whole hell of a lot better at what we're currently doing.
What a beautiful way to end, huh? So I wanted to just take a moment if any of the panelists would like to share any of books, papers, websites, resources, or anything that you want to share, please. I think folks are interested, but as a way to sort of close this out.
I will share our website is medicatingnormal.com. To reach us, it's medicatingnormal@gmail.com. And if we are so interested in speaking to different groups that if anybody has any ideas, just put us in touch with someone and we'll do the legwork on it. And please visit our website. You know, it has upcoming screenings. We have an educational distributor, so the film is getting into colleges and universities and across the country. And we have an international distributor, and it's being broadcast internationally, but not yet here. That's coming. So just we'll keep you posted. Thank you so much for being here.
So I just let everyone know, Free Range Psychiatry is my organization, and it's, so the website is Free Range Psych, spelled PSYCH, although you could also spell it out. They both go to the same place, .org. And yeah, so I forgot to mention too, like, so in addition to what we're currently doing, we're providing care, a lot of care for patients one-on-one. We also just launched the fellowship. We have some volunteer opportunities, so you can check those out. All this information, we have like a lot of information on our website. I'm kind of obsessed with having lots of information out there that people can look at. And soon, and by soon, I mean, probably in the next couple of months, depending upon how things go, we're going to be launching essentially like an online support community for people who are wanting to come off of psychiatric medications. And in that support community, we're going to be offering all kinds of cool stuff like yoga classes and cooking classes and just all kinds of like general tips. And it's going to be a non-medical thing. So in other words, you don't have to be a patient. It will just be open to the public, which is great because that means you can be in any state, you can be in any country, because it's not something that, it won't be a medical service that we're offering, which would mean we could only do it in certain places. So it's going to be really kind of just totally open to the public. So yeah, that is coming probably at least a couple of months away before we get that up and running. But we are really excited to be offering that, because I can definitely say that I have heard from many people that it is something that I think would be really, really helpful, because there is just, I mean, there's so little out there, so yeah, that will be coming.
So I have a radio show. It's called Black Mental Health Matters. It's not specifically about medications, just about mental health in the Black community. It's on a radio station called 98.1 FM, The Urban Heat, and the website is heat981fm.com. It's on Sundays at 1 p.m. On Eastern Standard Time. And if you want to check out the website, it's drkerryann.net. That's drkerryann.net for the radio show. I also have another website that's just Kerry Ann WIlliams MD.com, which is just for my private practice. So if you want to connect with me, you can find me on Instagram and Facebook. Dr. Kerry Ann is my handle.
For me, usually I plug the film, but Lynn already did. So I'll just say, please follow us on all the social media networks if you want. If you want to look at my stuff in particular, just by me trying to reintegrate my life, I have a page called Being Human RV on Instagram and Facebook. If you want to watch me in the messy and the clean and the good and the bad and all of it in between. But otherwise, please follow us, the film. We put out lots of good articles and content all the time. And thank you for having us.
Thanks, everyone. Thanks so much for being here and for such a wonderful, rich discussion and for an amazing film.
Bye-bye.